Medranda. Dr. Robles Medranda is the head of endoscopy at Ecuador's IECED. He's the director of the ASG Endorsed Pentax Training Center. Dr. Robles Medranda is a luminary interventional endoscopy. With training in France, Brazil, and Japan, he excels in EUS and third space techniques, earning accolades like the ESG 2021 Best Innovation Award. He's also a prolific researcher and educator. He has trained over 100 global endoscopists. His pioneering studies on endoscopic therapies continue to shape the Latin American international guidelines, making him a visionary in procedural innovation. He began us to talk today on EUS-guided vascular therapy. We're excited to hear from you.
Thank you so much for this kind of introduction and this kind of invitation. For me, it's the first time here. I'm very glad and honored to be here in this amazing course, so congratulations. My next lecture is about EUS-guided vascular therapy. So this is my financial disclosures. EUS-guided hemostasis is an evolving technique with the potential to improve the care of patients with refractory variceal and non-variceal gastrointestinal bleeding. EUS-guided treatment of varices with coils and/or cyanocolate is effective in active bleeding and for primary and secondary bleeding prophylaxis. So I will talk about now EUS-guided vascular therapy in gastric varices. This is a little bit the schematic way that we can see gastroesophageal varices and isolated gastric varices, as well as the anatomy. Is very important to remember how it works regarding the anatomy, because this is very important when we will take a decision for this kind of treatment. So we need to, what is the rationale for this kind of therapy performed by EUS? First, that we have a visualization in B mode and Doppler mode, so we can differentiate between arterial and venous in terms of vascular, the vascularity that we are looking. So second, the security for vascular access. So we need to remember that the wall of vessels histology, we have a muscular layer, and we have to remember also the vessel pressure. So the possibility to make an angiography, possibility of injection or deployment treatment through the needles, no scars, less morbid mortality, and ambulatory management and cost effectiveness. So just as a schematic way of the important steps, so first anatomy, second diagnosis, and third the access. So what are the techniques that we have nowadays? So we have the injection therapy, we have the deployment therapy, and we have the combined therapy. So this is the materials that we can use. I love to use 2-octyl cyanoacrylate injection. I believe it's much better and security for the patients and also for the machines that we are using, the scope that we are using. I will talk about EUS-guided injection therapy. So this is a patient that came to our unit 2017. This patient was sent because of upper GI bleeding. So when we saw, it didn't show it any kind of gastric varices, but then we passed the EUS because we needed to see, and you see this thrombosis on the splenic vessels. And this patient had isolated gastric varices. You can see here, this is the feeder vessel, so you can see here. So this is very important, I believe, when we are doing this kind of treatment, to search the feeder vessel, because it's a way to make the treatment. So radiologist doesn't make the treatment directly on the gastric varices, they do it through the feeder vessel. So once we detect it, I use it, in this case, a 22-gauge needle. And you can see the variceolography. I like to use a lot this kind of angiography to evaluate if there is any kind of shunt or how is the vascular anatomy that we will do a treatment. So in this case, for example, we can see that this is the segmentary hypertension, and you can see this is a small vessel, so the risk of embolia or embolization is really low. And in this case, I decided just to make a treatment just with glue You can see I am doing the application of the glue here very well. And then this treatment allowed the patient to recover and go home and prepare for a surgery, because this patient had a segmentary hypertension because of a secondary surgery, secondary to a surgery. So I would talk about EUS guided deployment therapy. So this is the first study published by the European group in 11 patients, showing that the technique using cyanoacrylate or coils was effective for gastric varices. So the first conclusion that they evaluated was that the use of coil required fewer endoscopy and tended to have fewer adverse events compared to cyanoacrylate injection. However, they explained that large comparative studies were needed to prove this data. So this is a patient that had a shunt, and in this case, we just use coil, pure coil, but you can see here, this is the feeder vessel. You can see here, this is the feeder vessel. In spite that it was a small feeder vessel, so when we, at least when I am using, just coil, I try to use more coils to really perform a good embolization. And you can see here, after the treatment, when you did it inside the feeder vessel, the gastric varices disappear, as you can see here in this video. So you can see immediately the disappearance of these gastric varices, and you can send the patient home if the patient is doing well. So I will talk about combined therapy. So this is the first large series from the United States from Dr. B. Muller. With 152 patients, the successful treatment was more than 99%. The mean of coils was 1.4, and the mean cyanoacrylate injection 2 ml. The complications reported were abdominal pain post-procedure in 3% of cases, pulmonary embolization in 1%, and bleeding post-procedure in 3% of cases. One of the limitations of the original technique that was showed by Dr. B. Muller is that you go directly to the gastric varices become hard because you put inside the glue and the coil, but at 3 months of follow-up, the limitations are bleeding risk because of 2.6% of cases due to coil migration to GI tract lumen that could happen, as you can see here. So because of this, I try to talk a little bit with the radiologists, how they do it, the technique, because we need to learn from them. They have a very big experience. So the original technique proposed to perform the coils and the glue inside the gastric varices, but when you talk with the radiologists, they say that they don't do it, that they do through the feeder vessel. So this is why we try to do the modified technique, trying to looking for the feeder vessel. And this is how the portal hypertension goes and opens the left gastric vein very clear and makes it appears the gastric varices. So as a modified technique, we saw that we can do a lot of things like good angiography. I believe it's a good advantage because we can determine the feeder vessel and number of diameter of coils that we can use to confirm the gastric varices by angiography to avoid splenic vessels, confirm obliteration by angiography and Doppler, and determine the correct side of the bleeding vessel. So this is the original technique. So we use some kind of cases when I start this technique in 2015. So you can see here, we go directly in the gastric varices, and here we try to, in the modified technique, we try to see the feeder vessel here. You can see here, this is the feeder vessel. So with it makes me be sure I have 2 tips. First, I can flush with saline solution. You will see here. This is already published in Digestive Endoscopy 2019. So you see the gastric varices, I'm sorry, So then I flush with saline, and you can see it goes directly to the gastric varice. So, and also at the same time, when you do contrast, you can see the feeder vessel, and this is the left gastric vein. So you are in the correct position, and then you can deploy the coil, and then you can deploy the glue, and again, you can see the disappearance of the gastric varice. So our first publication with 30 cases was in 2019. We saw that the reintervention-free interval cumulative incidence curve was higher in those patients, and the overall survival and reintervention-free was much better with patients with this technique. So just to show it a little bit, why varicellography is important, in this case was recently published in a few days ago in our YouTube channel. So what I want to show you here, it was this. I think this is very important. Well, I tried to show a little bit how the shunts are. This is not the good video, I'm so sorry. I tried to put directly the presentation from YouTube, but here is not possible. But well, what is going on is that in some kind of cases, varicellography, it not just detect the shunts. In those cases, I just use coil. But in this kind of cases, when, you know, a big quack is inside the fundus, so it's very difficult to detect the gastric varices. In this case, this patient was under hypovolemic shock. You can see just after volume or intravenous volume, we can achieve to see the Doppler, and then I try to see if I was in the correct, you know, feeder vessel. So you can see here. So you can see here, sorry, you can see here the feeder vessel as well. Where is the rupture? You see this is a gastric fundus. So I was very sure that I was in the feeder vessel, you know, and I stopped the bleeding, just putting a coil and then a glue, and this patient recovered after 48 hours and sent home. So we performed a first randomized study, clinical trial comparing coil versus combined therapy, cyanochelate injection and coil. What we saw is that EUS guided coil embolization with cyanochelate injection achieved excellent clinical success with lower rates of rebleeding and reintervention than coil treatment alone. So we saw immediate gastric varices disappearance in almost 90% of cases, 10% more of cases of complete obliteration, 10% of less rebleeding, 14% of prevention of gastric varices reappearance with less of 14% of reinterventions, and 27% of gastric varices reappearance in the coils alone group after 3 years of follow-up. So this is another case that we had with a big vessel, but even if it was a big vessel, you can see here the feeder vessel was really a small vessel. So you can deal better with this kind of cases, you know, and a complete obliteration, you know, just with one coil was achieved, and glue, and then the immediately disappearance. This is another case. This is a case that we performed using the endosound machine that we performed a live case yesterday. So it is possible. This was a pediatric patient. I did it in endoscopy and nerve a few years ago. So when for first time, we showed this technology. So you can see this is a plastic, you know, endosound, and this is a standard gastroscope. So we use a 19-gauge needle. We went inside, we put a coil, and then we put the glue, and you can see complete obliteration of the gastric varice. And this is our last study, published just by abstract on the last year in DDW. So this is the 8-year follow-up of our patient. And what we saw is very interesting things. First, that in 67% of cases, up to 3 coils were required with a median injection of 3.6 ml of cyanocrylate. So I used more glue. Second, 100% of technical success was achieved. Among 167 patients, 8.9% experienced recurrence with a median of 4.9 months. In the multivariate evaluation, we saw the lower recurrence associated with previous beta blocker therapy, previous band ligation, and the high risk for factors for recurrences was previous cyanocrylate injection. It means patients that were treated before by standard therapy using the gastroscope and just cyanocrylate injection, they have more risk for recurrence. It is very important to understand that in 30% of cases we can have more than one feeder vessel. In this case, we see these 2 feeder vessels. You can see here, you can see one here and the other here. So it is very important to identify those cases and do and perform a complete obliteration, because this is one of the cause of reappearance of the gastric varices when you don't perform a good treatment in these kind of cases. So this is what happened in those cases that has been previously treated. So I think this case is very interesting that we had a few years ago. This patient was treated 3 or 4 times by glue in another region of my country. So this patient, when we received it, he was intubated in intensive care unit like 10 days. And what we saw was embolization. You see a pulmonary embolization because of the treatment that they do it. It was very difficult to identify where was the vessel, but we achieved to see exactly the correct vessel here, and you can see here after 28 days after treatment. So this patient went home in a good condition after this. So in terms of cost effectiveness, we performed this study in 2021 in which we compare the standard technique versus EUS guided coil and cyanocrylate injection. For sure, cost per procedure, it means each procedure that we perform, cyanocrylate injection, the standard, the gold technique is much, is much cost effectiveness. But when we see the number of endoscopy procedures, the length of hospitalization, including intensive care units, the total procedure cost, hospitalization cost, and total treatment cost, procedure plus hospitalization. So we can see that is more in favor of US-guided coil treatment and cyanocrylate injection than the standard technique. So this is recent meta-analysis, and there is another one from GIE in the last few months showing that the combined therapy for sure is much better than than single treatment using US therapy. So it confirmed the results of our randomized study, and it's also showed that this should be the technique to be performed. In the future, yes, vascular therapy can be reached also in some kind of cases when contraindication for hepatocarcinoma or chemoembolization is difficult in some kind of patients. So this is a case that we do last year. So we perform vascular therapy in this patient, making an obliteration of the artery. You can see here. So we perform the iodine contrast to see if we were in in the correct, artery feeder vessel for this tumor. So in this case, we perform the vascular therapy, but also we perform our combined therapy with radiofrequency. And also in the future, microwave technology can be the standard technique treatment also for inside the vessel and make a coagulation from inside. This is just, the necrosis after the treatment and the ablation therapy. So this patient is doing well in spite that she had a contraindication for chemoembolization. And so maybe we can see in the next future more treatments guided by EUS. So in conclusion, endoscopy therapy remains the gold standard technique in the management of gastric varices. EUS-guided hemostasis is safe and feasible with excellent result for gastric varices. EUS-guided hemostasis combined therapy should be the technique of choice and in the future could replace the standard technique. So thank you so much for this kind invitation. I would like to invite you to our online live course in August. It's for free. So go into our webpage and, and enjoy it. Thank you so much for this kind invitation.